Welcome back to the Exam Room podcast with Dr. Rhiannon Windsor. In our last episode, Dr. Satya Sarma introduced us to the foundations of value-based care, challenging us to think beyond volume-driven healthcare and focus instead on delivering meaningful outcomes for patients. We explored what value-based care really means, why patient-centered care matters, and how a strong model of care can improve both health outcomes and the patient experience. In this episode, we take the next step, from philosophy to implementation. Why do so many healthcare organizations struggle to make value-based care work in practice? How can health centers identify patients most at risk for poor outcomes? And what systems need to be in place to proactively support patients before they end up in the emergency room or hospital? Join us as Dr. Sarma shares practical strategies for turning value-based care from an idea into a reality.
We're back in the exam room with Dr. Satya Sarma, a physician leader and healthcare executive with experience spanning public health, Medicaid, and payer systems. We've been discussing what it takes to move value-based care from concept to reality, and now I'd like to shift our focus to why good ideas don't always translate to practice, right? So here's my first question. What are health centers still getting wrong about value-based care?
Great question. I think it goes back to what we talked about earlier. I think the fundamental source, most important source of failures in implementation really boils down to breaking out of that volume-based model. To your point, value-based care usually gives you a return after the fact, after you've achieved. So that can really start being a barrier to resourcing or utilizing resources at the clinic level in a way that drives success. So once again, if we're focused on volume, you would set your entire system up a certain way. But if you're focused on value, how would you allocate resources as an executive at a clinic? It would look very different. You would actually pay more attention to things that maybe you don't get reimbursed for from a fee-for-service perspective, but which you know or believe are going to drive better outcomes for that patient. So remember, in value-based care, and say, for instance, in the shared savings model, it isn't just what that patient costs at your clinic. It's what happens after they leave. If they end up with an expensive emergency room visit or a long hospitalization that was potentially avoidable if you just spent more time with them in the clinic or had more attention to them with a case manager, in a shared savings, in a value-based model, and certainly in shared savings, that can go very spectacularly against you. Part of the challenge is aligning on value-based care as the founding principle from the executive level all the way down to the line clinician or line employee, frankly. I think that's where I think a lot of the friction comes about, because what I've often encountered as I work with clinics to establish their care models is, I'll say, well, we'd love to, call our patients and make sure that they did get their medicines or that they do have transportation. But we have only so many case managers, and those case managers are supposed to hold a panel or manage a panel that's at least this big. And that means we don't have time for that call. Well, if the lack of that call means the patient ends up back in the emergency room in the next few days, what the executive team needs to realize is that's what ends up adding up and creating those issues. So it's really about aligning that vision all the way down, being consistent in the implementation of the model of care, being as sophisticated and as continuously improving your ability to identify high-risk patients and also resource their needs.
So would you say that most health centers are juggling more than one model of care?
Yes, for the most part. When I set up my clinic, I started by taking every payer I could think of, really. I signed up for everything because, in the system we're in, where third-party payers are your predominant source of revenue as a clinic, most clinics tend to have multiple payers with multiple payment schemes. And that's so that patient in their community can come see them. And so they can build their panels. So for instance, patients who go on Medicare, on fee-for-service Medicare, or patients who sign up for a Medicare Advantage plan, or patients who are on Medicaid, or maybe have both Medicare and Medicaid, all of these, from a payer standpoint, can have different structures in that volume versus value.
If there's a said health center that is focusing on this fee for service, and then let's say they get this wild hair and they decide, like, oh, we're going to join an ACO, or we're going to now start thinking about this in a different way. Like, what does that transition look like? To me, it seems like they kind of get stuck juggling these two, and they never really do what you say, where they stop and they reassess top to bottom. Okay, value-based care is now going to be our model of care, and this is what it looks like moving forward. Like, how is that even accomplished?
Yeah, it's not easy. I think
This is a big question.
You're right. For the most part, people are transitioning away from a system that required them to do a set of things to be successful and to be sustainable. And here they are in a situation where it needs to be nearly the opposite,
Right.
in some respects. Some things need to completely flip to be successful. This is where actually models like the shared savings plan are meant to help, because the shared savings plan actually works on the members, the patients you have in that shared savings plan are people who are covered by Medicare fee for service. But what's different is you're basically saying, well, I think I'm going to do, as a clinic, you're saying, I think I'm going to do a great job of managing these patients. And instead of being in that rat race of more is better, I'm going to this program where when I do a great job and give these patients what they need, help them become more stable medically and address all their social and behavioral needs, even though that will mean that I have fewer claims to send out fee for service, I think by doing a good job, I'll actually generate a lot of savings that Medicare is going to share with me. That's the concept behind shared savings. But you're right, and I think when you look at, some of the big names in healthcare that have come up, like Iora Health, Oscar Health, basically, those are all practices. They're actually setting up practices that compete with individual or well-established community clinic. That's because they're trying to set up their system to succeed in value-based care from the outset and then go compete for those contracts. That's their argument for their business case, right? Is we know that the existing system is set up ways of doing things that just don't help you succeed in value-based care. We're going to focus on all the things that we think ought to help. Now, does that mean they provide better care? I don't know, because, as I said, it depends, right? But what we really need is for the system as a whole to think in those terms of how do we drive value. You're 100% right. Part of the issue is transitioning. And how do you do that? One way to approach this is start by focusing on your high-risk members. So who's at the risk for the worst outcomes? It typically, particularly in a Medicare population, is people with chronic conditions or multiple chronic conditions. Let's start there. Let's try to see if we can change our way of doing things for those to start with. And then as we get good at doing that, we can then go on and, incorporate the system for, this new way of doing things for everybody.
20% of the patients drive approximately 80% of the cost. So, are we doing this well in our health centers, identifying these high risk peoples?
it starts helping people bridge into well, how do I do this without breaking the bank, right? So this idea that 20% of patients are responsible for 80% of costs, that's across the board. Medicare has published those numbers for years. What that means is that if you focus on that 20% and helped them get the care they need, if you help them avoid avoidable, unnecessarily having to go to the emergency room, you can make an outsized difference in terms of your financial success in a value-based model. At ABC Network, we are basically working with our FQHCs to identify the key things they need to do to become successful with those members. In our survey, what we find is most of our clinics have the ability to identify high-risk patients. We help them with that through data models that we can bring to bear. So it's actually there are a number of risk scores that have been developed over the years. They were in use by insurance actuaries for a long time, right? So, and we've added some clinical elements to it to be able to try to identify who are high-risk members. So we do have a methodology for it. Now, how good is it? The only way you can really answer that question is by measuring next year whether you really did a good job of identifying your high-risk members that were there this year, and then refining your model as you go. In general, we have a fairly solid idea of how to determine risk through the years, and those principles are part of our ability of our work that we do to basically highlight who's high risk in the clinic's panel.
So we give them the data. It shows them who's high risk.
Right. We actually send them a roster of their members that are high risk. We've been doing that for a while now. So we've been identifying who is high risk amongst their panel, and then we've been sending them a list that says the names, the addresses and the numbers for those patients so they can contact them and make sure that they see them.
Yeah, so that was going to be my next question. Like, once the health center has this very valuable information, it seems to me that it would be very valuable. Like, what does it look like now in practice at the health center once they get that information?
The first step is to make sure that these patients who we've identified as at high risk for bad outcomes are engaged in care. Well, let me ask you, how many, for instance, insured patients do you think see their doctor at least once a year in general? Just pick a number.
Like a percentage?
Yeah.
Okay. 65.
The number is usually closer to 50.
Okay.
If you were to take all comers, about a half of us,
Okay.
we go out and we get insurance for ourselves and our families. And then about half the time we actually go and see the doctor in that given year, right? It's not unusual to see numbers from 40 to 60%, but I've never been at a health plan that wasn't somewhere around 50% when we first started. So what that means is we've got high-risk members who we don't even really know what state they're in as their clinician, because we haven't even laid eyes on them yet this year. We don't know what's going on in their lives. We don't know what the state of health is. We don't know if they're taking the medicines they're supposed to be on. We don't know if they've run out. We don't know when they might end up in an emergency because they haven't been seen. And the first we hear of them, they're already in the hospital. They've already had a bad outcome. The first concrete step we're taking is basically making sure that we have a mechanism and a workflow to contact these members, these patients, and bring them in, or at least contact them and see what's going on with them, and engage them in their care, because sometimes you get a call from your doctor out of the blue and you want to know what it's about, right? So it's really about engaging those patients, saying, we care. We care enough to call you and say, we want to know how your heart disease is doing. We want to know how your diabetes is doing. Come in and see us. Or at least let us have a call and go through what's going on with you. So the first sort of core thing we're working on is engaging those patients. The other two things we're focusing on this year as a starting point are transitions of care. So one of the things about particularly patients who are at high risk is some of the bad outcomes that we see are, more likely to happen right after an event like an emergency room visit or a hospitalization. So now what that tells you in a chronic patient is things got out of hand. We didn't have it under control. They didn't have their condition, in a stable way. It got unstable. They ended up needing emergency care or inpatient care. Well, many of the bad outcomes happen after that event. If they go home and they got emergency treatment, chronic conditions don't cure. They just become controlled. But they had one event, and so it's already unstable. It can get into more trouble if they aren't getting the follow-up they need. The same with the hospital. The second thing we're working on is, do we know who those patients are who went into the hospital or the ER? And are we getting them back in a timely way? Again, we identify this on the list. So if you've got a high-risk member who went into the emergency room or the hospital. And then the third thing we're going to be working on this year is really, you talked about the pyramid, about how 20% of the patients, don't, cause 80% of the healthcare expense. Well, if you think of that as a pyramid, right, there's 1% of patients who are really driving a big number of the costs. So people who are really sick, right? I mean, we know this from our own lives, right? Like we know someone, a family, or, God forbid, our own experience where some kind of a health issue was so bad that it led to a lot of care that we needed, or a lot of, think of the cancer patient, or the patient with immunologic diseases, or you name it, right? Like bad COPD. So there's 1% at the very sort of top of this pyramid that often drives a lot of the expense. So one of the patterns we often see when we pull data on high-risk patients is, let's say that there were 5 emergency room visits in that last quarter. 3 of those 5 were from the same patient. So now you tell me, what does that tell you as a clinician? Doesn't it tell you, well, this person needs more of our attention, more of our time, more of our insight? So that's what we're going for, is a strategy where we identify high utilizers and really step in to try to prevent that 4th visit, or maybe have another quarter where we've controlled their problems enough so they're not having to go into the emergency room so often. That involves a lot of things, including things like, working with them to say, well, here are the signs that things are starting to go off the rails for you. When that happens, pick up the phone and call us. And of course, that means that you as a care team have to be there to take the call. if I'm an asthmatic and I can tell that I'm using my inhaler more, and, I'm not able to control it with all the strategies you gave me, and I call the office and then I don't hear back from you for a week, that's not what we want. We want patients to say, and we want the clinics to say, I know that patient was on my high-risk roster. I know we've been working on a plan. They're already engaged. They're doing what they need to. So we want a system where we've got more attention on these patients and give them the high touch they need, so that they drop from that 1% back down to more of a stable chronic condition category.
This might be a really crazy question, but what about the other 80%?
Yep. Good question. And that's why I said this is a starting point, right? So a model of care is really your approach to the patient as a whole, to your entire patient panel. A model of care really should say, here's going to be my approach for those patients who are well. Maybe all they need is an annual visit. And then maybe there's another layer of people who have one thing wrong with them. Maybe they broke a bone, or they needed a hip replacement, but they're otherwise well. What are we going to do for those patients? What are their needs? Maybe they're more able to just use self-management tools, right? For the most part. But a portion of them might still need some help from us. And there's that other layer with maybe this layer, self-management might be a strategy. So maybe you want to develop some education for those patients. You want education for all the patients, but maybe you focus on that as a strategy that would help, right? So that if all I have is diabetes, but it's pretty well controlled, you're giving me a resource where I can go, whether it's talking to your doctor or talking to a dietitian or, pulling up something that you've developed for me that says, okay, is it okay to eat that tiramisu I'm really craving? Or at what point should I worry? Like, if my sugars are going up and down, like, how should I handle that? These are the things that you can have a strategy for patients who are not quite in that 20% at the top of the pyramid. So a model of care really addresses every single level and layer of those. I will tell you this. I think this is hard for people to envision. But what I've seen happen when clinics start thinking about patients according to what they need and giving them their attention and their expertise based on what they need, care improves for every level. Because, what you've done there is you completely changed the way the clinicians think about their job. That's the transformation that ultimately ends up happening in my experience when you work with, you're really changing your approach to care, and you're letting your clinical heart drive that as opposed to purely your financial needs. Not that those don't exist. I ran my own practice and I had to make rent and, pay my staff and so forth too at the end of the month. So I'm not trying to minimize the need for, healthcare to be sustainable economically. But what you do with value-based care is you really turn a switch, you flip a switch in the approach, in the mentality, in that relationship. In my experience, it's also much more satisfying to do value-based care well from a clinical perspective, because like I said, typically people don't go into medicine to make a ton of money. If they wanted that, there are lots of easier ways. If there are any young people out there who are like, my goal is to make a lot of money, you got a lot of options. I would not put becoming a clinician amongst them. It's not likely to make you a lot of money, but it is likely to really fulfill you professionally. It's really likely if you have that service mind, right? You care for people and you like caring for people and you enjoy those interactions, it can deliver a lot to your life, more rewards than can be measured, frankly. You'll have a lot of stories to tell, not just your children, but medical students who come after you, or nursing students who come after you. So,
absolutely. I mean, we say the same thing in education, right? We're like, yeah, you don't go into education if you plan on getting rich, but me, I've been in healthcare education has been my focus. And it's the same thing. You care about patients, you care about sharing your knowledge with others, which trickles down. I mean, you and I talked about this before. Like, it's all about the patient care, that, it's all about those outcomes for the patient and taking care of the communities that we live in. And it kind of brings to mind another thing about like black and white thinking, the equity versus the equality. And I can remember in my past, I had this one faculty member. She was military trained. Not that that's bad, but she had this very black and white thinking. Like, why are we giving this student one tutoring session and this student is getting 4 tutoring sessions? Like, she was so stuck on the equality and not the equity piece of things. And I think it's so important for us to always hold that in our mind and interacting with any person in any relationship, but most importantly, I think in the healthcare space.
That's a great example, actually. And you're right. That's another caring profession, right? That we can't do without.
Today's conversation focused on the practical side of value-based care, identifying high-risk patients, improving care transitions, and creating systems that proactively support patients before they experience a crisis. As Dr. Satya Sarma shared, successful value-based care requires more than data and strategy. It requires a fundamental shift in how healthcare organizations think about patient care. In our next episode, we'll explore the leadership side of healthcare transformation. Dr. Sarma discusses clinician burnout, the importance of supporting frontline healthcare teams, and why clinicians should have a stronger voice in the decisions that shape patient care. We'll also examine how healthcare leaders can build cultures of continuous improvement and create environments where both patients and care teams can thrive. Join us next time as we conclude our conversation with Dr. Satya Sarma on The Exam Room.